Thank you for your invitation. It was a very interesting topic to discuss, and the previous speakers speak very well about that. But it's very important to improve the result of the instability and recurrence of dislocation. We have already seen the different points. It's very important to have a good clinical selection of the patient, and you need have clinical findings very well. The range of motion and stability test, active compression test, biceps load test, crank test. But the most important test for me is the Gauge test. He appreciate very well the hyperlaxity, and you can appreciate the quality of the inferior capsule. But Pascal Boileau had made a very interesting work about the anatomic factor assessment of the instability of the shoulder. And the bone is very important to check. You need to appreciate the glenoid erosion and the glenoid rim, the glenoid fracture, and Christian Gerber described very easily index to determine the bone loss of the glenoid surface. But the 3D reconstruction is very interesting to appreciate the bone loss of the glenoid side. But the capsular injury is very important to check, because there is very frequently stretching regarding the number of the dislocation or capsular insufficiency. And you see on the right the damage of the capsule, and you have no capsule inferiorly, and it's a typical agal lesion, and it's very difficult to repair, and you cannot have a good result if you make a soft tissue procedure. Hill-Sachs lesion is it's very important to check too, especially the deepness and the engaging of the Hill-Sachs lesion. It was very beautifully described by Burkhardt and Jodebir. You see engaging on the right and non-engaging on the left. Itoy describes the glenoid tract, and it's very, very good appreciation of the risk of engaging of the Hill-Sachs lesion. After the anatomical assessment, you can have two different options. If you don't have any problem with a bone, you can repair the capsule if you don't have any problem with the capsule too. And for me and for a lot of European people, Bankart repair and remplissage technique is the best way if you have a Bankart lesion with Hill-Sachs lesion. If you have a small bony Bankart, I mean, it's possible to repair, especially for the fresh lesion, because you can have a good fixation and healing of the piece of bone. If you have a glenoid fracture with a big bone loss or capsular ligamentous damage, stretching or agal lesion, or combination of both, it's different. If you have isolated the Bankart lesion, it's the best way to repair the capsule. Pascal Boileau described 4 types of lesion we can find with only glenoid side on ligamentous stretching, or 3 lesions with glenoid side, ligamentous side, and humeral side, and only ligamentous damage. If you have just detachment of the capsule from the glenoid side, the best way is to repair by the Bankart procedure. If you have a stretching of the of the capsule and ligament, it's very important to make a good shift and to repair as well. For the indication of arthroscopic stabilization, if you have just damage of the capsule, it's a good way for repair the capsule and make a remplissage technique. If you have bone loss, you see the history. The best technique, if you have a good capsule, is Eden-Ebinet technique, arthroscopically described by Ettore Taberna and Mark Schebel, or some allograft on anterior bone graft. If you have a capsule and ligament damage and glenoid bone loss, the Latarjet procedure is the best way, because you can have effect. You have a good effect on the stability of the shoulder, but you can use also the Tria technique if you have some insufficiency of the cuff, especially with the cuff tear. It's the best way to stabilize the glenoid side as well. Thank you for your attention.